Thank you, Rolando, and thank you all for being here. It's not very often that I have an opportunity to speak to a large group like this here locally, and so I thought I'll start by telling you how grateful I am for the support of all of you, Rolando and every single one of you, for the way that every one of you have contributed to the work that I'm going to present here. I get the pleasure of taking the credit for most of it, so thank you for that. But I thought I'll take this opportunity to share with you that credit because much that from time to time we had a good idea, if it wasn't by our collective effort, none of these would have become a reality. And I must say that when I speak of a collective effort, and I don't mean to get too political right away, but we need to acknowledge the fact that the provincial government has been spectacularly supportive of our work, and it doesn't really matter what stripes you wear on your outside of your academic environment. But I have to say it's been a pleasure to work with Victoria, both the Minister Terry Lake and the Premier Chrissy Clark have continued to be extremely engaged, extremely supportive. And it's through their support that we've been able to do a lot of the stuff that I'm going to tell you here now. So what I plan to do is walk you a little bit historically over the developments over the last few years in terms of HIV and AIDS control in British Columbia, and then slowly take you into how this has helped us shape the global fight against HIV and AIDS, and how this has actually opened the door for the new global targets, the 90-90-90 targets. So with that in mind, let me first deal with the formalities. This is my conflict of interest disclosure, and as per UBC guidelines, you have there the management and mitigation strategy. I take full responsibility for the presentation and the slides, and as far as therapeutic recommendations are concerned, rest assured that whatever I'm going to say is totally in keeping with the guidelines from the center, which are in due course reflective to a large extent, not exactly, but reflective of the IAS-USA guidelines, most recently updated in JAMA in 2014. So historically, as many of you are familiar, I like to start with this slide, which tells you what my life was when I arrived in Vancouver in 1981, totally oblivious to the fact that an epidemic was arriving at the same time. The early days in North America were rather slow, but by mid-'80s, we were in the midst of a real disaster. And by the late 80s and early 90s, we really didn't know if anything was going to be able to turn the curve, this red curve that you see here, looking at, in this case, annual rates of death for young men in the United States due to AIDS. Lo and behold, work that we had started here in St. Paul's, and I had the pleasure of leading internationally, the INCAS trial, was exploring in a phase 2B study the role of triple therapy using nevirapine as a cornerstone. In that trial, it was nevirapine, ACT, and DDI. And in December of 1995, famously, Mark Weinberg, who was doing the virology for us, approached me to ask me if there was something technically wrong with our samples, because in a proportion of them, he could not grow virus. Now, most of you are too young to know this, but before there was quantitative viral load measurements, the PCR assay, the only thing that we had to measure the impact of HIV was either CD4, which usually is too late, or the ability of a virus sample or a blood sample to grow the virus. And we used to use the time to growth of the virus, the time to positivity, as a reflection of how much virus there was in that sample. So that a person treated with ACT monotherapy, for example, would experience a delay on the time to growth of the virus. What Mark was telling me is that he could not grow the virus, and we could not explain why that was happening. Around that time, we had been given access to a new emerging assay, which eventually turned out to be the Roche PCR assay, John Siniski, a friend of us in Roche at the time, made that possible for us. And so when confronted with this, we retested blindly all of the samples that were available for the 6 months follow-up of the INCAS trial. And voila, in December 1995, we knew that there were a third of the patients that happened to be on one particular arm of the study that had achieved an undetectable viral load and that their CD4s were actually very good. That happened at around the same time that Trip Gulick from Merck 035, the Indinavir-based trial, was emerging with similar data from an ACT3TC Indinavir phase 2b study as well. And so we reorganized our program for the Vancouver conference, the 1986 conference, which was something that we had been working on for years without even knowing that there would be a hope in 1996, to basically use that as an opportunity to bring to the world the triple therapy news. It took the world by storm. We had already at that time very strong support from our provincial government, and so we were able to implement the triple therapy program immediately in BC with very rapidly declining death rates and an ever-increasing life expectancy. So really, this was the beginning of the end of the AIDS epidemic as we knew it. Now, we didn't really know how many more challenges were ahead of us, and that's the subject for another discussion. What I want to concentrate next is on some of the unexpected findings that came out of the obsessive monitoring and evaluation that our program has been characterized by. And so what happened was that while morbidity and mortality were coming down and life expectancy was going up, and we were all very pleased with all of that, we got a hold of this data, what you see here, and that actually was the first red flag that there was something else going on that we had not anticipated. And what happened was that upon rolling out antiretroviral therapy, triple therapy that is, we saw a decrease in the number of HIV new infections in British Columbia, despite the fact that at that time syphilis rates were going up. Now, for all of you smarty pants that think this is obvious, at the time it wasn't. And let me explain you why it wasn't. Because in retrospect, everybody can say, yeah, that's easy. If you have a patient with tuberculosis and you treat the tuberculosis, what you're doing is you're killing the mycobacteria. And so the effect of the treatment is immediate. The burden of bacteria decreases very quickly. And as my father taught me back in the day, the moment you start somebody on anti-TB treatment, effective triple anti-TB treatment, that person virtually becomes non-infectious. Now, you could not say the same thing about HIV back in 1999 or 2000, because the way HIV works is the genome, the genomic material of the virus gets incorporated into to your genome. And so your cells now carry that genetic information. If you take the blood of a person that is on treatment and you put it out into a culture medium, oftentimes, despite the fact that the person is appropriately treated, once you put it in a culture medium, that virus can grow, because the material, when you put it in a new medium, has no drug, so this is virtually the same as stopping the medication and therefore allowing that virus to express itself. Now, of course, it doesn't grow to the same extent if the patient wasn't treated, but it does. So the concern all along was that if you have a person that is infected with HIV with suppressed viral load and therefore undetectable viral load, if I were to have either sexual relationships or exchange body fluids, or you get a transplant from me, even though my viral load is undetectable, there would be enough genomic material there that it could potentially be reactivated and lead to a successful infection. And just to give you an example, you probably would not accept me to give you a kidney for a transplant from a person infected with HIV if you're not infected with HIV, even though that person may have an undetectable viral load. And that's basically the problem. So back in 1999-2000, the prevailing knowledge or understanding was that even with undetectable viral load, transmission could occur, And that was one of the reasons why nobody was prepared to state the fact that treatment equal prevention of transmission. However, our data suggested that something was stopping HIV transmission in an environment where syphilis was going up, and then we argued that the only thing that could explain that was antiretroviral therapy. So at that time, we brought together a group of us, including the Yuri group, Richard, and a number of others, to basically explore this issue further. And using our cohorts, we came up with a model that suggested that antiretroviral, in order to explain these findings, antiretroviral therapy would have to be at least 90% effective on decreasing the efficiency of HIV transmission. And that led to the paper that you're familiar with, published in The Lancet in 2006, where we made the case that expanding antiretroviral therapy coverage, that is, would lead to decreased morbidity, mortality, and transmission. And that's when we coined the notion of treatment as prevention. Prevention for all three things at the same time, whereby the prevention of transmission is a secondary gain of expanding antiretroviral therapy coverage. And so what we embarked on at that time was, to a large extent, a very intensive political sort of exercise to engage the political leadership in the province to secure the support to actually do this. And while the STOP initiative, as you know it, only became sort of formalized in the middle of what I call the phase 3, as you can see here, the expansion of antiretroviral therapy in British Columbia actually started probably around 2003, 2004. So what I'm going to show you next is the three basic phases of the expansion of antiretroviral therapy in BC. Prior to the summer of 1996, virtually nobody was taking treatment, only the subjects in the INCAS trial. Between 1996 and 2000, roughly, you see a fairly rapid expansion of treatment, but then by 1999-2000, people started to get nervous that side effects, resistance, complexity of the treatment, so on and so forth, were compromising the sustainability of the effort. And so patients and doctors started to avail themselves of treatment interruption strategies and treatment deferral strategies. And so for a number of years, we entered this phase 2 where there was a concerted effort to minimize treatment exposure until such time as the SMART trial was published in the New England Journal of Medicine, showing that treatment interruptions and delaying of treatment initiation were both associated with worse clinical endpoints for people infected with HIV. And this happened at around the same time that we had new agents, particularly tenofovir, that came to replace D4T and DDI, which by that time we had learned were more toxic than we wanted them to be. And so that combination of factors allow us to reopen sort of the doors of our treatment program, but now with an eye onto the treatment as prevention proposition. Again, preventing morbidity, mortality, and transmission. And through successive efforts, we were able to secure resources to both expand the availability of treatment, but also to expand our outreach support and everything else that goes with it. So what was the impact of all of this in terms of morbidity? I thought I'd share with you the full history of the AIDS epidemic. I am happy to tell you that I learned this week that a paper that mostly Viviani was working on was accepted by the Lancet HIV and will be out February 13th, describing the morbidity mortality impact of antiretroviral therapy in British Columbia for the duration of the epidemic. Basically what you see in these next couple of slides. So the first phase here, pre-HART, you see a very steep increase in the number of AIDS cases, comparable, if not faster, rising curve than you saw in the first slide that I showed you for the United States. You see that when highly active antiretroviral therapy became available, then the number of AIDS cases decreased very promptly. But I always make the point that availability of treatment did not completely address the issue. Notice that the new nadir here was in the order of 100 to 200 cases per year, say 150 cases per year, while the peak here was approximately in the 600 to 700. So yes, we had a huge impact, but no, we had not yet solved the problem. And it wasn't until we moved on to a more aggressive rollout with treatment and prevention in mind, where we liberalized the access, facilitated the access, supported testing, etc., that we saw a significant decrease in the number of new AIDS cases diagnosed. I use this slide to reassure people that the expansion of treatment from hard availability to treatment and prevention actually has had a morbidity and mortality impact. The mortality impact is illustrated here. You see hard brings down mortality quite significant, 350 down to about 50 per year, yet it doesn't quite go away almost completely until we embrace treatment and prevention. And I'll describe this for you in a fairly simple way by saying that the Canadian healthcare system is extremely good. Basically, we have the services that people need to access available to you, me, us, all of us. However, because the system is designed in such a structure that there are various silos, the pharmacare silo controls the drugs, the acute care, the primary care, the community care, the who knows what care, laboratory services, it doesn't matter. They're all different silos. So what happens is that all of that creates a culture of basically trying to reduce the exposure of each one of those silos to particular issues. So in other words, the way the system works is, yes, heart is here and it's available for you, but rather than being here, it's actually here. And I call that a draconian Darwinian perversion. I love that sentence, so let's try it again. It's a draconian Darwinian perversion. Why? Well, it's draconian because it ultimately is counterproductive. It's Darwinian because it actually favors the survival of the fittest. And it's a perversion because it's all wrong. So what we're doing is we're having a service that should be here, and we bring it here and say, come and get it. So if you're smart and well-connected, Rolando gets diagnosed with anything. He gives me a call and says, Julio, what am I supposed to do here? And I'll say, okay, don't worry, I'll fix that for you. Ta, ta, ta. And in 15 minutes, he's where he has to be, and he accesses the services. Now, if you have the same person that has other challenges, social-cultural, economic, mental health, addictions, poverty, other competing priorities, etc., rural versus urban, you name it, that is going to determine that your ability to negotiate access to these services, that it's your right, they are supposed to be there for you, it's just impossible. It's just not going to happen. So all we've done with the treatment and prevention campaign is we have broken the silos, we got all of the system to talk to each other, and then we brought the services to the people in a facilitated fashion. So we encourage people to screen for HIV testing, to engage on treatment. We offer navigators, we offer support. You could say we could do more, yes, but we have more resources today for care and support, testing and access to treatment than we ever had before. Why? Because we were able to make the point that investing a little bit more on facility and access is saving lives, is saving in terms of public health, new infections, and it's also saving in terms of money. To prove the point that this actually contributes to healthcare sustainability, as you know, this has allowed us to re-profile, the editorial calls it closing, but really we haven't closed anything, re-profile our AIDS world services. And yes, that was a bit of a political statement on our part, but we needed to make the statement so that people understand that, yes, through this effort, we now have freed up a 10C ward that has been basically reopened to address the longevity issues related to HIV and the challenges that we're facing increasingly in the injection drug using community. So that's what it's all about. If we could subtract everything that is there taking room in our healthcare system and open those same resources to things that we cannot deal effectively with, that would be a huge contribution to healthcare sustainability. Now let's talk about HIV transmission or new infections. This is probably the one thing that is really has not been celebrated enough in British Columbia or elsewhere for that matter. And that's the fact that we have virtually eliminated vertical transmission of HIV because treatment is the best form of prevention of mother-to-child transmission. We don't need a mother-to-child transmission program. If all women infected with HIV are on treatment the way they should be for their own benefit, then their children will not be born with HIV. And what you see here is a sample of 300 pregnancies over a decade, within which only 2 children were born with HIV infection. The expected rate of transmission would have been such that somewhere between 30 to 100 children would have been born with HIV. We only have 2. And in those 2 cases, the reason why they were born with HIV is because the mother was diagnosed too late. So prompt diagnosis of HIV during pregnancy, or even before pregnancy for that matter, is the best tool that we have to ensure that those 2 cases don't happen. Unfortunately, social, cultural, economic, and comorbidity factors will always be there to mess our best plans. But what this is saying is that in the real world, we can have a real impact on HIV transmission, at least in the vertical setting. And when you look at new diagnoses overall in the province, you see that new diagnoses have declined really in a way that is inversely proportional to the number of people that have been treated, as shown on the red line, the number of active people on heart. And that trend continues. I have not included here a stratified analysis for IDU and non-IDU. Suffice to say that we have had the greatest impact in the IDU community because of the synergy between highly active antiretroviral therapy and our addiction program, in particular our harm reduction program, that by itself reduces the likelihood of HIV exposure. We have been less successful in MSM because really we don't have a lot of measures that come to the help of heart. I'll address that further in a moment. Now, when you look at the spectrum of HIV transmission throughout the country, you'll find a chart that looks like this, and it's pretty pathetic in my opinion. BC on the red shows remarkable decreases. We used to be twice as prevalent as any other region in the country. Today we are continuing to go down very satisfactorily. We are the only jurisdiction that has had a decrease of that magnitude. Manitoba, here on the light green, and more in particular Saskatchewan, are showing very significant increases in HIV new diagnosis, predominantly driven by epidemics in First Nations and epidemics related to IDU, sometimes overlapping those 2 factors. At the end of the day, the thing that differentiates BC from the rest of the country is that, number 1, we have a programmatic focus, and I think that that's crucial. We have a programmatic focus that pertains to HIV. We are here to deal with HIV and nothing but HIV. When you have, like in other provinces in Canada, BC practitioners, ID, internal medicine, family law, it doesn't really matter, public health, who are there to address their epidemic, but at the same time they had to address anything from Ebola, like if it was going to happen here, right? Or mumps or TB or whatever, at any level. What happens is those people are going to be paying attention to what is coming through the door. What we have been unable to do is to convince them that they need to go out to look for HIV because this is an amenable epidemic, and they need to deploy resources to go after it as opposed to wait for it to reach them. And so that expectant attitude, that passive attitude in the rest of the country is what is hurting them. When I talk to the Minister of Health, for example, in Ontario, and their public health leadership, they tell me, we have everything the same as British Columbia. And my answer to that is, but you don't have the same results. And the reason why that is because, yes, they have everything, but they have it right here. And they don't understand that the secret is to have a programmatic focus to bring the services to the patients and then, or to the community, and then they will see the same results that we see. That's in one hand. The other hand is political leadership. Let alone our leadership, that doesn't really matter. Anybody can copy that. But political leadership is very difficult to duplicate. And what we have had in the most unwavering and singular way in BC is the support of our public, through them, our politicians, and with that, the resources to do this. Unfortunately, federally, we have little hope that this is going to change. So we're currently working with the provinces to try to inform them about the progress that we have made, and hopefully they will emulate what we're doing. There are signs that that's happening, not as fast as we would like to see it happen, but there is a lot of noise happening in the rest of the country. Suffice to say that last week I received a call from the Governor General's office inviting me to spend the afternoon in the downtown east side with his wife, Your Excellency, who refuses to be called Your Excellency, and she wanted to be called Sharon, who was extremely candid in her opinions, which I'm not at liberty to share, regarding the value of insight. So if the Governor General and his wife get it, I think there is a significant degree of optimism on my part that times are changing. The other thing that needs to be considered is that this is not just about people's lives. Of course, that's of paramount importance, but even for those that are less caring about the issues that we care so much about, the money implications, the financial implications of the work that we're doing are tremendous. And this is preliminary data developed by Bob Hogg some time ago that we are waiting for the board and Nozick to give us the final verdict on this. But nonetheless, what it shows is that the savings from averted HIV cases, anything above zero is savings. Anything below is actually, you're mortgaging your future. British Columbia is actually saving money as a result of spending a little bit more upfront. Saskatchewan, for example, is mortgaging its future because of the lack of attention to the HIV epidemic. So this is a very real concern when it comes to dollars and cents. My good friend Ruben Granich, formerly from WHO, then UNH, and now IAPAC, published this paper in February 2013 that basically summarizes this issue in the context of South Africa. And this is a mathematical model, but what it says is that at that time, if South Africa was to move from the baseline of offering treatment late at CD4 counts of 200 to 350 to 500, or to test and treat, in other words, treatment of prevention, offering treatment to anybody immediately upon being diagnosed with HIV, they would save tremendous numbers of lives, 5.5 million lives saved by 2050 in this model. When it comes to the money, of course, treating more people becomes more expensive. You see from the blue to the red to the yellow to the light blue. But the beauty of this is that investment is needed for a short period of time. Very quickly you hit the baseline, and then the more you invested up front, the more you save. So that going for a test and treat would have saved South Africa, for example, nearly $30 billion by 2050. So not only saving lives, but saving infections and saving tremendous amount of money. And this is the kind of work that we have used to convince our colleagues globally that this is the way to go. So with all of this information, we started a very concerted effort to convince our global colleagues and the global leadership that there was something here worth exploiting. We were able to outline for them the promise of antiretroviral therapy in terms of preventing HIV-related illness and disability. By the way, putting people back on their feet and putting them back to work, preventing premature death, and preventing HIV infection. I don't need to expand on these things. I think that that's very apparent to all of us. Bob Hogg's paper recently in the PLOS ONE updated the survival expectation of a 20-year-old infected with HIV today who has access to immediate antiretroviral therapy. And he currently estimates that that could be measured in the order of 5.5 decades. So that person today is almost approaching near normal longevity with a reasonably protected quality of life. And not only that, but also a normalized or near normalized reproductive life, which is also critically important. It took a little bit of time, but eventually Myron Cohen published in the New England Journal of Medicine in 2011 the results of the HPTN 052 that verify our epidemiological and ecological data, suggesting that treatment prevented transmission in the order of 90% or more. And his estimate was that immediate treatment decreased the likelihood of transmission by 96.3%. In fact, if you take that same study and you analyze the data, excluding the first few weeks that it takes for somebody to become undetectable, the protection afforded by antiretroviral therapy was 100%, which is not too bad, I'll say. Now, the question had been all along, would we be able to show the same degree of association that we saw in British Columbia in other areas of the world? For example, KwaZulu-Natal, one of the most affected areas in the world, but also one of the most poor areas of the world. And on that note, the paper by Tanser in Science in 2013 is extremely important because what they did, and I'm not going to go into the details, they used geographical mapping of antiretroviral therapy coverage to the village level, and they paired that with incidence data, again, using geographical mapping at the village level, and so they were able to correlate coverage with antiretroviral therapy versus HIV incidence. And the results are as shown here. The incidence goes down as coverage goes up. But to me, the beauty of this was that the estimate of the relationship of this association was exactly the same order of magnitude to what Viviani had been able to characterize in our Lancet paper. I believe it was in 2010 or something like that. Where we basically found that for every 1% increase in antiretroviral therapy coverage, there is a 1% decrease in estimated HIV incidence, exactly the same level of magnitude or the association that it was shown in South Africa. And more recently, my good friend Andrew Hill from the UK used global data to plot incidence of HIV here versus antiretroviral therapy coverage and death versus antiretroviral therapy coverage, and he showed basically at a global level the same kind of relationship for both. So the strength of this association is actually irrefutable, and it basically operates wherever you go. So that's very comforting. There has been a lingering doubt out there in the scientific circles regarding whether or not these findings would apply to every risk group or most affected group affected with HIV. And the biggest concern was whether or not it would these results would be equally meaningful for MSM for a variety of reasons, many biological reasons, the role of asymptomatic STIs, or sexually transmitted infection, so on and so forth. And so our colleagues in the UK started an effort a number of years ago to try to address this. And so what they did is they recruited a large number of heterosexual and homosexual serodiscordant couples. And they measure the likelihood of transmission as a function of the viral load in the index member of that couple. And what they finally found, this is by 2014, when they presented 2-year follow-up, this is incomplete data. We expect that the full data set should be available in 2016. But in the meantime, with over 1,000 couples evaluated, they found that the overall risk of HIV transmission, as long as there is adequate viral suppression, was 0 for heterosexual and for homosexual couples. Now, let me be clear here. This is zero-link transmissions. In other words, this is looking at me and my partner, whether it's heterosexual or homosexual, doesn't matter, transmission from me to my partner or whatever. What antiretroviral therapy of the index member of the couple, namely, if I'm the positive, my treatment is not going to protect my partner if my partner has sex with somebody else, because that will depend on the status of the other partner. And so the great difficulty is that in order for these results to translate into significant decrease in HIV transmission, and I'm talking about the biomedical component of it, I'm not addressing the socio-behavioral and other components, but from an antiretroviral therapy treatment prevention perspective, in order to protect this individual, we're going to need to have a very high level of coverage to ensure that occasional partners are not going to basically compromise the treatment prevention effort. The other issue that we needed to address before we could go sort of real-time globally with this strategy was the continued tension between treatment prevention on one hand and other biomedical prevention efforts. The ones that are really more prominent are medical male circumcision and tenofovir or tenofovir FTC PrEP. And this became a very significant part of the discussion. The first point that I'm going to make is that if you look at treatment of prevention, as I said, you're treating a person infected with HIV for reasons of preventing morbidity and mortality, and you get a secondary prevention benefit that is as close to 100% as it's going to get. So that's really pretty good. When you use MMC, which is the medical male circumcision, you get a pretty decent effect, but not quite as much. Since this is a relatively inexpensive one-off proposition, it makes sense to accommodate it. Things became a little bit more confusing when you look at pre-exposure prophylaxis, because if you were to honestly look at this data, you'll find that the estimate of the efficacy is all over the map. And what happens is that at the end of the day, people had to take the medication in order to derive the benefit. And so adherence is a very important driver of the equation. But it's just as important when it comes to preventing morbidity and mortality. The problem is that a person infected with HIV has a daily reminder that they need to take the pills because it's for their benefit. For the person that is uninfected, that he doesn't know if he's going to have an encounter, a sexual encounter, tonight, this week, or the other week, and so on and so forth, incorporating pre-exposure prophylaxis is more complicated. So the operational optimization of PrEP is what remains a challenge, and we're hopeful that a couple of studies that are going to be presented next month at CROI, or within a matter of days now, are going to help us to better understand how can we optimize PrEP so that we can make a better part of the package, or an integral part of the package. Now, having said that, I want to emphasize something that most discussions omit, and that's the fact that treatment as prevention is something that we are committed to, because I think we most readily agree that every person infected with HIV either needs treatment right now or imminently or very soon. But the likelihood of an HIV-infected person to be without treatment for decades is actually remote. The current guidelines, even the WHO guidelines, which are fairly conservative, recommend that people start treatment at the very latest when they have CD4 counts of 500. People infected today will be, if they are infected and found very early, they will have a CD4 count of about 500 for a matter of months or a couple of years. But we're not talking about deferring treatment for a very long time. So treatment is on the cards for the first person infected with HIV. The prevention benefit related to the treatment program is actually derived for free. There is no additional infrastructure. There is no additional anything. We're basically fulfilling our commitment to make treatment available to people infected with HIV. Everything else that you see here is less effective, and it requires a separate infrastructure. In other words, I had to set up a PrEP program if I want to do PrEP, or a male circumcision program if I want to do that. And so then you enter into a different discussion, which is the return on the investment. The return on the investment of treatment and prevention is simple. If it is for free, everything you get from it is for free. Not in morbidity and mortality, but the prevention benefit for transmission is for free. Everything else here costs you dollars and cents. And in economies that are compromised, where the dollars for treatment are difficult to secure, talking to ministers of health all over the place, I can tell you the decision, at least to what they want to prioritize, is very simple. Treatment comes first, the rest comes second or third. The province of British Columbia, once again, very quickly, upon completion of the preliminary analysis of the STOP initiative, agreed to expand the program to the whole of the province. And so we are currently embarked on a province-wide expansion of treatment and prevention, which I'm quite happy about. And I'm happy to also tell you that while we're not discussing male circumcision, because that's a practice that is fairly prevalent here anyways, we are discussing what role other biomedical strategies will have, including PrEP, as well as PEP and NPEP and so on and so forth. So with all of these, some of it better sooner than others, etc., we engaged in a discussion with our friends at UNAIDS. Michelle Sidibe was actually appointed in 2009. That was around the time that I was finishing my tenure as president of the International Society. So I had a pretty good opportunity to spend time with Michelle. And eventually Michelle did a site visit to UBC and St. Paul's in 2010, which basically was the pivotal moment where he realized that this is what they needed to do. And so he embraced treatment and prevention as of then. In 2011, believe it or not, I have yet to receive an invitation to visit our Prime Minister's office, but having been at the White House 3 times, we were able to move the Obama administration to embrace treatment and prevention, and to a large extent, this was because of the strong support that Bill Clinton provided us starting in 2006, when he actually truly embraced the notion that treatment and prevention would be the cornerstone of the control of HIV and AIDS going forward. We've been everywhere. This is the Vatican, and this is Archbishop Zygmunt Cimoski, who is the equivalent of the Minister of Health for the Vatican, and I'm happy to tell you that even the Vatican gets it. So, and we're still talking to the Vatican about this, and I'm expecting to meet with the Pope in weeks to come to see where do we take this conversation further. In the context of all of this, I was asked to lead the United Nations discussions regarding the new HIV therapeutic strategy and AIDS control strategy. As you know, the United Nations has what we call the Millennium Development Goals. They are due to mature in 2015. The Millennium Development Goal for AIDS was 15 million people on antiretroviral therapy by 2015. I'm happy to tell you that we are this close to having 15 million people on antiretroviral therapy globally by 2015. Unfortunately, that's not enough. And so Michelle asked me to lead his team in trying to crystallize the treatment and prevention work that we have done here, plus the work that I described around the world, to see how we can use that to galvanize the UN and ultimately come up with a new post-2015 Millennium Development Goal that he a priori established would have to be ambitious, and it would have to contribute to writing the final chapter of the AIDS epidemic. Fairly tall order. And so we defined the objective at that time, and we said, look, what we want to do is to maximize the effectiveness of existing tools by 2020 to virtually eliminate progression to AIDS, premature death, and HIV transmission, and thereby transform the HIV/AIDS epidemic or pandemic into a low-level sporadic endemic disease by 2030. And we define that as decreasing the burden of disease by somewhere in the neighborhood of 90% compared to 2010 levels. And that's where we propose the so-called 90-90-90 target, which basically says that by 2020, we would like to encourage countries around the world to have 90% of all people living with HIV diagnosed, and at least 90% of those engage on high-quality, sustainable antiretroviral therapy, and at least 90% of those achieving virological suppression. Now, it's true, it's very difficult to conceive how we can do this when we don't have a viral load assay in, say, South Africa. I'm happy to tell you that within a week of announcing this, the viral load became available in South Africa. And not at $100 a shot, but actually at less than $10 a shot, which makes it readily doable. That's a way of me illustrating the fact that the targets are actually driving the investment and driving the availability of some of these tools. By the end of 2015, we anticipate that somewhere around 37% of the people infected with HIV globally will have viral suppression. Now, that's an estimation because it's not been measured. We want to turn that upside down. And by 2020, we would like to have not 37, but 73% at least of those living with HIV to be virologically suppressed, a threefold increase over the number that are currently virologically suppressed. Notice that the previous Millennium Development Goal was 15 million by 2015. That's one single number, and it has no qualifiers. There is no quality attached to it. As long as you sign on to a prescription once, you get counted. It doesn't mean that it's sustained. It doesn't mean that it's optimal. It doesn't mean. So we wanted to fix that, and so we created a new target that has three elements that we believe fundamentally define the cascade of care. So for you to meet the 90-90-90, you have to optimize your cascade of care, meaning that it brings some sense of equity for all of those that are infected. It also incorporates morbidity, mortality, and transmission as part of the goal, and it encourages incremental funding. The 15 by 15 basically says, as long as you started 15 million people on treatment, you can walk away and you'll be fine. What this is saying is not. We want you to treat everybody, and we want you to sustain that effort for the duration. Eventually, we had the opportunity to bring this to the United Nations General Assembly. That's my good friend Pedro Can, who was with us, among others in the back that you may recognize, Diane Havrir, Wafal Sadar, etc. That's the core group that developed the 90-90-90 target. And at that meeting, Ban Ki-moon actually formally signed on to the 90-90-90 target as the preferred proposed United Nations post-2015 Millennium Development Goal, so that for the next year, we will be focusing on securing the support of each one of the member countries so that by 2016, in September at the UNGAS, the United Nations General Assembly, we will be able to ratify the 90-90-90 as the new global target for 2020, so that by 2030 we can have hopefully the beginning of the end of the epidemic. I'm happy to tell you that at that event, the President of Switzerland, President of Mali, the President of South Africa, each one of them stood up and they gave a little speech and they said, yes, we will support it. In fact, John Kerry stood up on behalf of President Obama to express the support of the American administration. So we're moving. I actually taken the freedom before that event to invite the PMO to be present, and they basically told me, Julio, we're not going to object to it, but don't expect us to support you either. Shame on them. The issue now becomes whether or not the 90-90-90 is a realistic proposition. And let me just say very simply that today nobody has met the 90-90-90, not even British Columbia. So we have a lot of work to do if we're going to get there or get even close to that. The question is this totally unrealistic? And so what we did is we went to the country level, region level, and we look at where things are at. First, starting with the antiretroviral therapy guidelines. And so what I have here for you is the evolution of the antiretroviral therapy guidelines based on the WHO guidelines. Now, let me remind you, the WHO guidelines are based on the past. So they're going to provide guidelines today for the work that has been done until today. The targets are for tomorrow. So necessarily, we are way ahead of the guidelines. And that has created a little bit of tension. However, I'll point out to you that this slide, which was actually sourced from the WHO, the presentation that they did in 2014 in Vancouver at the Treatment Prevention Workshop, they actually acknowledged that in 2014, the new guidelines at that time were here, recommending treatment for CD4s below 500, as well as for serodiscordant couples, pregnant women, children less than 5 years, people who infected with tuberculosis, and people who infected with hepatitis B, regardless of the CD4s, and with treatment for life. So already the guidelines were making eligibility of antiretroviral therapy a fact for somewhere around 29 million people, at a time where there were 34 million people living with HIV. What that means is that even if we were to use the old guidelines, and let me remind you, we're now a couple of years removed from that, what those guidelines would allow us is to...
PASU, second floor, Burrard. Code blue, PASU, second floor, Burrard. Code blue, PASU, second floor, Burrard.
So those guidelines would allow us to actually offer treatment to in excess of 75% of the people. So at the end of the day, the targets are not really contradicting anything that the guidelines say. What we're saying is that even if you want to use the old guidelines, if you implement them optimally, you should be able to meet a 90-90-90 target. What we're saying is that why bother all of that money that you're going to spend on screening to defer 5% of people in terms of access to antiretroviral therapy? You might as well invest it on putting people on treatment and simplify your program. So at that time, we came up with the scenarios. The status quo, which in many countries is rather pathetic, they continue the current pace of enrollment, which is slow in many areas of the world, fully embrace the 2013 guidelines, which would be a dramatic improvement over what we had to date, or forget about all of that and just go for a test and treat approach, which we think will make all of these more feasible, consistent with North American and now increasingly European guidelines, and at the end of the day, simplify the programs. Now, when we asked our modeling group, led by John Stover, to look at what this would do, quite clearly, I show you here the status quo and the 2020 target. What you see is that new infections would dramatically decrease with the 2020 target, and AIDS death would decrease significantly, less so than we were hoping for, because in developing countries, there is a lot of hidden comorbidity that will unfortunately be very difficult to get rid of. These are people who have either asymptomatic or undiagnosed tuberculosis and other opportunistic infections, who, even if we roll out very quickly, those people are going to run into problems. And so 1 year mortality of people already infected is going to be very difficult to bring down to the levels that we see in North America. But nonetheless, what you see here is that the difference between these two lines is dramatic. Everything else would be somewhere closer to the green here or closer to the red, making it totally non-appealing. And so the question becomes, as Penny Ballan told me when she was the Deputy Minister of Health here in British Columbia, Julio, your program is great, but in certain circumstances, even a Cadillac may not be affordable. So we need to ask the question, is this actually affordable? I told you it's cost effective. I told you the return on investment is huge. But if you actually don't have the dollars and cents to actually buy the program today, then it may not be doable. And so my good friend Brian Williams did this analysis where he looked at universal antiretroviral therapy as a function of GDP. And what he found is that in a majority of countries, this falls well below 1% of GDP. In a number of countries, falls between 1 and 2%. In a modest number of countries, between 2 and 5%. And there are only about half a dozen countries, or less than half a dozen countries, where the rollout of treatment of prevention, as we discussed it, would be in the order of 5 to 8%. Now, if you look at this closely, you're going to see that, unfortunately, those that have higher costs are often the countries that have higher prevalence. So that's a bit of a tough second message. But what this is saying is that doing this at a global level is doable, is affordable, and with relatively modest international cooperation targeted to the countries that actually need the support, we should be able to actually do this. So now moving to the targets. Are the targets realistic? Can this be done? Can we test 90% of the people? Well, we argue that yes, because there are countries like Rwanda that is already doing it. Can we put 90% of the people on treatment? We would argue that yes, because Botswana is actually approaching that level. Brazil is approaching that level. Can we have high retention in this program? Well, Latin America and the Caribbean actually are not doing too badly. At least some of those countries are approaching 90%. Can we achieve high levels of viral suppression? Well, if you look at in Rwanda by clinics or jurisdictions, you see that the levels of suppression is very high. Maybe coverage is not that high, but if you look at these independent markers, it suggests that we could be learning one from each other and then cross-fertilize across programs so that we can make it happen. So we think that the 90-90-90 by 2020 is actually doable. It's ambitious, but it can be done. And if we do that, we may well be about to write the final chapter of the AIDS epidemic. Would this be the end of AIDS? No, it's not the end of AIDS. It's the end of the pandemic. AIDS will not be eradicated, if that's what you want to know, until we have a vaccine and we have a cure, or probably both. So we need to be clear. We can dramatically decrease the burden of disease from pandemic to endemic and diminish the tax that AIDS has imposed in the most affected communities. Will it end? No, it will not. And if you allow me, I'd like to finish with this slide. It's a picture of my good friend and collaborator, Jupp Lange, who has been a huge supporter of all of the work that we've done here and together. When challenged, Jupp was actually the head of the WHO program back in the day when the 3x5 strategy was first crafted. And when he was challenged that treatment could not be made available to people in Africa, he basically used to answer, if we can bring a bottle of Coke, in fact he used to say a cold bottle of Coke, to every corner of Africa, we should be able to also deliver antiretroviral drugs. Jupp was tragically murdered when the MH17 fell in Ukraine in July 17, 2014, and really affected all of us very dearly. As the 90-90-90 was presented by Michel Sidibe, just as he was going to stand up to make a presentation in Melbourne, and not in any way staged by any of us, the community stood up representing the south of the world with placards asking for undetectable viral load. Little did they know that was exactly what Michel was going to recommend as part of the 90-90-90. I took this picture because I thought it beautifully closes the circle. The science driving Michel, the policy driving the community that drives the science, that drives the policy, and hopefully we're at a point where the 90-90-90 will be approved, and we will, in the not too distant future, be able to celebrate the end of the pandemic. Thank you.